Hello, welcome to the webinar. My name is Natasha Halasa. I'm a professor in pediatric infectious diseases at Vanderbilt University Medical Center. Today's topic will be influenza disease and vaccination in stem cell transplant recipients. So these are my disclosures. In the past, had received funding from Sanofi and Quidel, current funding for Merck. The vaccine studies I'll talk about, Sanofi donated the vaccines and did the HAI testing, which we'll discuss further, and I will be discussing off-label indications. So briefly, I'll take you through influenza disease and epidemiology, and then specifically talk about influenza vaccine strategies. So just a question for the audience. Obviously, this is, we're not in a group setting, but it's just something for you guys to think about. If you had a 47-year-old that was 4 months after their stem cell transplant, and now the vaccines are available in September. If they're 4 months out, would you administer influenza vaccine? Yes or no? And if you would you give this individual 1 dose of standard, 1 dose of high dose, 2 doses of standard, 2 doses of high dose, or 1 dose of live attenuated vaccine? And hopefully after this webinar, we'll have a clearer picture what works well. So influenza is a member of the Orthomyxidae viridae family. It's a single-stranded RNA, has 8 segmented genomes encapsulated in a lipid-containing envelope, and has 2 major surface proteins. This is one hemagglutinin and neuraminidase, and both of these are important for naming the strain as well as in the vaccine and measuring protection. So there's 4 types of influenza: A, B, C, and D. Influenza A is the most common, and H1N1, H2N2, and H3N2 are ones that are in humans, but you can see many different animals, and when there is a mixture, we can see some human influenza infecting humans. So further, not just only the types, but the subtypes. Currently, we have H1N1 and H3N2 that are circulating. Pre-pandemic, we had B Victoria and B Yamagata. So far, we actually have not had any B Yamagata since the pandemic. And it gets further subdivided into clades and also subclades. And they use this specifically when they're trying to find out if the circulating strains match the vaccine. So when we talk about a strain for influenza, we talk about the type, the place of isolation, the isolate number, the year of isolation, the subtype for influenza A only. And an example here would be A, California, isolate number 7 in 2004, H3N2, and then B, Shanghai 361, isolated in 2002. So an antigenic drift is a minor change within the same subtype, and this can be caused by point mutations in the genes. You get new variant strains, and it may result in an epidemic where you get a new pool of susceptible hosts, and this is one of the reasons why we get yearly influenza vaccines. So an example of a drift would be in 2003 and 4, we had A fusion H3N2, which was the dominant virus, but then in 2005, A California 7, 2004 for H3N2 began to circulate. When we talk about an antigenic shift, that's a major change for a new subtype. It's caused by an exchange of the gene segments, and this may result in a pandemic. And so an example of an antigenic shift is in 1957 to 1967, we had H2N2, which was circulating. And then in 1968, it was replaced by H3N2. So a pandemic, how do we define it? It's when there's a new influenza virus that emerges for which people have little or no immunity, for which there's no vaccine. The disease can easily spread from person to person and cause a serious illness, and it can not only sweep across the country, but around the world in a short period of time. So this is a timeline of 1918 was the first documented influenza pandemic caused by Spanish flu. And then you can see 57, 68, 77, and all of us were around for the 2009. When the next one will be, who knows? One thing I want to show here, and this is what pretty much most infectious diseases, where at the bottom you'll see a U curve, and we'll talk about high risk. So when we look at kids that are less than 5 years of age, having the highest morbidity and mortality, as well as those that are over 65. But something that was interesting in 1918, and we saw this again with the pandemic, is that the young adults also had increased risk. This, if you ever want to see what's circulating and what the season looks like, and you can look in the past, CDC always has outpatient visits for influenza-like illness. You can see with influenza, sometimes we can't predict when it's going to peak with different years. And after COVID-19, we know that for a year on this green line that it went away and then came back early. Currently, and you can find this on the CDC website, where you can see what's predominantly circulating, and in the orange and red is showing influenza A, which is predominated this year by H1N1, and then B lineage, which we're only seeing is Victoria. So looking at the clinical manifestations for influenza A and B, predominantly respiratory, but we learned in the 2009 that 25% of children actually presented with GI symptoms. Flu is abrupt with coryza, conjunctivitis, pharyngitis, and a dry cough, but also associated with upper respiratory, croup, bronchiolitis, and pneumonia. And rarely you can get myocarditis and encephalopathy. I like this because it shows you one where the peak viral titers will happen, and then on the x-axis is looking at days. So both looking at symptomatology, so where you have the worst symptoms is early in the first 2 days, as well as peak viral replication. And this is one of the reasons why we recommend for those that are not high risk to give influenza antivirals in that 48-hour period. So when we look at complications, not only can influenza cause severe illness by itself, but can be associated with secondary bacterial infections, acute otitis media, bacterial infections like group A strep, Staph aureus, Haemophilus influenza, and strep pneumo, acute hemorrhagic pneumonia, myositis, that's mostly seen with influenza B, and they can even get rhabdomyolysis and renal failure. It's rare, but can happen. Myocarditis, toxic shock, and it's severe in those with underlying cardiopulmonary disease, and unfortunately associated with death. This here is looking at the rates of influenza hospitalizations and by age groups, and just not surprisingly, those that are 65 and older have the highest hospitalization rates. When we look at rates by age and high-risk groups, once again, if you can see that nice little U curve, but when you look at high risk compared to low risk, they definitely have higher hospitalization rates in those that are 5 and older. One thing you want to look at with the low risk group in less than 1, that the rates of hospitalization are just as high as those in the older age group. So when we look at influenza and high risk groups for complications, who are they? Individuals less than 5 years of age, 50 years and older, those that have chronic lung disease, including asthma, chronic heart, metabolic disease, chronic renal, high risk of aspiration, immunosuppressive individuals, which goes along with our cancer and as well as stem cell, pregnancy, Native American, chronic aspirin. And what we found in the 2009, that obesity was also high risk for complications. Here, it's looking at adults and children and looking at the percent of what underlying medical conditions. There's just 2 things I want to point out. For children, those pediatricians in the audience, and is that 50% of those that are actually hospitalized as kids do not have an underlying medical condition. And those in females that are childbearing aged, 26% of those that are hospitalized actually were pregnant. Even though this is about vaccines, I just want to briefly touch that you can find on the CDC website what are the current treatment and prophylaxis recommendations, and it gives you the age groups, and very nicely will also give you the dosages that you can use. There was a nice study even looking at solid organ transplant when they looked at ICU and non-ICU, and we've seen this in multiple studies. This is just one that I'm pointing out, where if you give antiviral treatment early, that they're less likely to be admitted to the ICU. So what about influenza in immunosuppressed individuals? So children with cancer and influenza. So this was actually reported in the 70s by Feldman, where he reported prolonged duration of influenza symptoms, that they're more likely to require hospitalization. There was high rates of delay in chemotherapy administration. And when they compared it to healthy controls, that those with cancers actually even had higher frequency of influenza infections. Also, complications, hemophagocytic syndromes, more likely to have concurrent bacteremia. We all saw in 2009 there were serious complications associated with influenza H1N1, and that immune suppressed individuals can shed virus for prolonged periods, and this can lead to nosocomial outbreaks of influenza. A more contemporary study that was done in Seattle once again showed, when they looked at influenza-related encounters and those with severe, that chemotherapy delay was 100% in those with severe, and actually 40% in those. So not only just having severe infection, but also delaying chemotherapy, which can have long-term consequences. When we look at influenza and stem cell transplant patients, it's an important contributor of mortality rates ranging anywhere from 15 to 17%. And then when you actually subtype it by those that have pneumonia, influenza mortality rates will actually go up. And it's even increased risk for those that have GVHD. What are some risk factors for severe influenza in stem cell transplant recipients? It's been reported that lymphopenia, older age and younger age, less than 5 in children, having associated neutropenia, those that have influenza very soon after transplantation or chemotherapy, if they're on steroid treatment or lack early antiviral therapy, and those with immune suppressive individuals can also shed virus for prolonged periods. So not only promoting nosocomial influenza outbreaks, but it's been reported both in the 2009 and subsequently it's been associated with the development of antiviral resistance. So what about prevention? Why do we need to have an influenza vaccine every year? One, for practical reasons, the influenza vaccine expires in June 30th of each year. Antibodies will wane throughout the year. And as we talked about earlier, there is surface antigen drifts as well as rarely, but can happen as a shift. So when we look at the vaccine efficacy, so right now with the standard influenza vaccines, those that are less than 65, it depends on what's circulating. If they did a good job figuring out the strain, it can be anywhere from 40 to 90% effective. Those that are frail and elderly, if they get the standard dose, it was been reported to 30 to 40% effective. For preventing hospitalization, 50 to 60% preventing hospitalization, and even higher if you're looking at ICU admissions, and 80% effective in preventing death. So when we're looking at the types of vaccines, so broadly, we talk about the inactivated vaccines that are given intramuscularly. Trivalent was originally, and then they saw that B was circulating in the B in about 10% of those. So they added the fourth B. Now that the pandemic has happened and we had community mitigation and non-pharmaceutical interventions, and the world shut down when influenza started circulating back, as of now, Yamagata is actually hasn't been detected. So WHO said for actually next year, they'll go back to the trivalent. It's recommended for all individuals in the US for 6 months and older, and not just high-risk vaccine, not just high-risk candidates. As far as the live attenuated vaccine, it's intranasal. Currently this year it's quadrivalent. It's only approved in the US for those that are 2 to 49 years, and it's only administered to healthy individuals. Strains, because they could possibly change every year, they try to reflect and predict what will be circulating in the upcoming winter months. So when you talk about the number of influenza doses, currently in healthy individuals, persons that are 9 years and older only need 1 dose. And this was actually replicated again when we looked at pandemic vaccines, that truly, if you're less than 9 years of age and it's the first time you're seeing the flu vaccine, you do need 2 doses. So here, if you've had for children that are less than 9 years of age, if they've already had the dose, they just get 1, otherwise they get 2. Currently, each year, the vaccines could stay the same or change, and depending if it's egg-based or cell culture. For this season, the 2023-2024, this is just the current ones that are included in there, and this is for your reference. Also, you can go and look on the CDC website that shows which vaccines are available. As well as WHO will for globally, and obviously this is a global conference, so each individual country will have their own specific recommendations and availability for influenza vaccines. So how do we measure protection when we're thinking about influenza vaccines? A major determinant of protection is the serum antibody to hemagglutinin. As we talked about earlier, that's one of the surface proteins that is important for influenza. And so I'll show you what this test looks like. It's hemagglutinin inhibition assay that's done. So they define seroprotection as one way is if you have, depending if you do a 1 to 8 dilution or 1 to 10, having a protective titer, which was associated with healthy individuals, that 50% of them were protected against influenza, was 1 to 32 or 1 to 40. We don't know in immune-compromised hosts what is the actual HA titer that you need to have to achieve protection. We know for seroconversion, you can start at a baseline, and if you get a 4-fold rise, that is known as seroconversion, is another way of measuring as potential protection. What we do know, especially in kids, higher titers are needed, and the higher the titer is associated with higher degrees of protection. So looking at the assay, it's a pretty cool assay. So if you just have the virus with red blood cells, because the sialic acid where the virus can bind to, you get hemagglutination. Obviously, no virus and just red cells, there's no hemagglutination. But if you take the virus and then you have antibodies that are specific to the virus that you're putting on this assay, then if you have high enough antibody titers, that they will then bind to the virus and not go to the red cells, and you get hemagglutinin inhibition there, and you see over there on the corner. So this is just what a patient serum sample specimens would look like. And so lowest titers is where there's inhibition, and then preventing the inhibition for the high titers. So looking at influenza vaccine studies in specialized populations, multiple studies have been done, especially when they compare to healthy controls, that their vaccine responses are poorer, as evident by lower antibody titers to specific antigens. And I don't need to really talk to this audience about this. You guys know this more and better than I do, that why they don't respond to their vaccines and due to their immunosuppressive drugs or their underlying medical conditions. So both having dysfunction not only in their cellular responses, but also in their humoral responses. So what about recommendations different societies will have, there's not harmony throughout. And ideally, I think part of this is that we don't have enough studies in this population. A lot of this is based on recommendations from experts. So when we look at the Infectious Disease Society of America or American Cancer Society, they do recommend the inactivated vaccine in all individuals 6 months and older. IDSA says to defer of anti-B cell antibody if they're going intensive chemotherapy, both ideally 2 weeks prior to chemotherapy. But due to a few studies that have been out there, the American Society of Cancer says between chemotherapy cycles is okay. As we said before, this was a nice small study that actually was done at Vanderbilt when over 25 years ago. He's now a hematologist, a pediatric hematologist, where he recruited children with ALL and then controls, and once again showed that the controls had higher responses, a fourfold rise, 89 to 65 for the H1N1, and also H3N2 and for B. Early in my career, Pat Flynn at St. Jude's led a very nice study, multi-center, just looking at the safety of live attenuated influenza vaccine with those that had mild to moderate immune compromised children with cancer. There was 9 in the the live attenuated group compared to placebo. We basically showed that this was safe, but they went on to do a second study to really look at immunogenicity, and it was still safe, but compared to the inactivated, the live attenuated actually had lower antibodies compared to those that had been activated. So pretty much going down the LAIV route for the mild suppressed was proven not to be optimal. So what about stem cell recipients? So IDSA says that you should have 1 dose of the inactivated influenza vaccine if you're 6 months of age, starting at 6 months. 4 months if there is a community outbreak defined by the local health department, and only if you're less than 9 years of age do they recommend 2 doses. The European Society recommends 6 months of age and older, but as early as 3 months, and that the second dose can be given possibly, but if you're going to give it, it should be given 3 to 4 weeks after the first dose. This was a really nice review, because one of the things you think about is like, why is there different recommendations, and what is it based on? As I said earlier, a lot of this is based on expert review. And so, and it makes sense because when you look at the sample sizes, it ranges only from 14 to the highest of 82. And these are all in stem cell recipients and looking at influenza vaccines. So that leaves gaps in knowledge. 1, we don't know what is the ideal dosing time in relation to phase of chemotherapy for cancer patients. And then what about after transplant? The number of doses per season. Should you give 1? Should you give 2? Route of vaccination. What about the roles of adjuvants? Some of the adjuvant vaccines are not recommended universal. I know in Europe, many countries do give that. And then what about dose? What about high dose versus standard? So 2 strategies that have been commonly looked at to overcome immunogenicity, especially in immune-compromised patients, not only in stem cell, but in solid organ and others, looking at 2 doses of the standard dose within the same season, or giving 1 dose of high dose. And so we talk about the standard dose, which is volume 0.5 ml, and then influenza antigen has 15 micrograms per antigen, depending if you do the trivalent, it's 45 total, or 60 But if you, just in the past couple of years, did we have a quadrivalent? Prior to that, it was the high dose trivalent, and it included if it was trivalent, it only included H1N1, H3N2, and just B Victoria. And that has 60 micrograms. The quadrivalent that is now out for high dose is 0.7 mLs and still has 60 micrograms of all four of the antigens. So looking at 2 doses of AS03 adjuvanted pandemic influenza vaccine in cancer patients, they looked at 197 cancer patients compared to 138 controls. And when you looked at 2 doses in cancer patients in the 197, they had a seroprotection of 82.3, which was very similar to 1 dose in the healthy controls at 87. And you can see very similar geometric mean titers. However, they did notice in a multivariate analysis that age and chemotherapy rate with rituximab was associated with lower responses. So what about the high-dose flu vaccine? So the high-dose flu vaccine, as I told you, has 4 times the antigen dose. We know we talked about it earlier with the frail individuals, especially those that are 65 and older, when they got the standard dose flu vaccine and they compared it to healthy controls, they didn't respond as well. So that's where the high dose 4 times the antigen came in, where they did a 2-to-1 looking at those that were 65 and older and compared the high dose influenza vaccine to standard dose. And you can see that geometric mean titer was 116 for H1N1, 609 for H3N2, and 69 for B. And you can see that they're actually lower. And what they do is they take the geometric mean ratio. So we take the ratio of the high dose, the 116, and divide it by the by 67, and you get a ratio of 1.5. And then for H3N2 is 1.8. And the goal was to have a geometric ratio greater than 1.5, and they did achieve that for influenza A antigens, and that's what led to the licensure. So then they did an efficacy trial where they enrolled over 30,000 individuals, and basically they were able to show that the high dose had a lower frequency of influenza confirmed illness, which gave it a relative efficacy of 24. So not only did it produce higher influenza antibody titers, but it was associated with protection. So thinking of the rationale that if those with ALL, solid organ, as well as adult stem cell, if they don't respond to the influenza vaccine standard dose, what about giving them a high dose? And so we conducted 3 phase 1 studies. With ALL, we showed it was safe, but we didn't find a difference in immunogenicity. In the pediatric solid organ, we can see over here that there was a higher rate of 4-fold rise, 56 versus 13%. And then in our stem cell transplant, the geometric mean titer was much higher, as well as protective titers had a higher percentage. And you can see the ratio here was 6.9. So this led to the rationale for us to do phase 2 trials, because 1, we proved that high dose TIV was safe. There was no major SAEs that were attributed to the vaccine. We had a safety, no safety profile was no different for the ALL pediatric population, and slightly higher local reactions were more common in the solid and the stem cell, but all of these were mild to moderate and resolved pretty quickly. These 3 phase 1 trials then led, I'm only going to talk about the first 2, but because these are the ones that are published, and I'm talking to hematologists and oncologists, but the first 2 pediatric stem cell and adult stem cell, but we also during these meetings found out that we want to look at the early transplant period. Then we excluded the lungs, but the lung individuals wanted us to study it there, and now we're going to look at it in the pediatric solid organ. So NIH sponsored phase 2 comparing high dose and standard dose influenza vaccine and pediatric stem cell. This was multi-center, so you can see the 9 sites and the individuals that participated. And for your reference, I'm going to highlight some key points, but if you want to read, these are our co-authors, and it was published in CID as well as the New England Journal of Medicine as a letter. And so both of these trials, I'm for the sake of time and also not for redundancy, I'm only going to talk about a lot of the methods, but they were actually the same for the adult, where the pediatric, which will be different, is we did 3 to 35 months post-transplant, 3 to 17 years inclusive. We randomized to 2 doses of the standard dose quadrivalent influenza vaccine, and then 2 doses of the high-dose trivalent influenza vaccine. Our specific aim 1, and this is the same exact specific aim for the adult, so I won't repeat it, is where we looked at whether the high-dose TIV compared to standard dose will increase by a 4-fold rise for HA titers. Will they have a higher protection of 1 to 40, and will they have a higher geometric mean titer to the influenza antigens? And then our second aim is to determine the frequency and severity of solicited local injection site adverse events and solicited systemic adverse events with the high-dose TIV compared to the standard dose. We had 4 visits. The first one was vaccine, and they had a blood. In order to measure safety, we called them and had them fill out a memory aid. At visit 2, we got blood again and gave a vaccine. I had them called them again and asked them to fill out a memory aid. And then this is where our primary endpoint at visit 3, where we're comparing the 2 doses to standard dose. So we just got a blood draw only. And then for thinking about durability at visit 4, we just did a blood draw only. These are what we collected for injection site reactions and graded it mild to moderate and severe. And same thing with systemic reactions, same grading of mild, moderate, severe, and as well as collecting a temperature. During the influenza season, if they had any of the following: a fever or respiratory symptoms, or any systemic symptoms, we asked them to collect a nasal swab. They stored it at a room temperature and then sent it to Vanderbilt, and we tested it for influenza. So for the pediatric population from 2016 to 2019, we consented 181 subjects. We enrolled 170, and pretty awesomely, 85 in each group. When we look at the demographics, the age median anywhere from 10.9, slightly younger in the standard dose compared to the high dose. Otherwise, everything was matched well, except you can see that the months post-transplant median for all was 7.8. It was slightly higher in the standard dose at 9.2 compared to the high dose. When we did the randomization, we did it from 3 to less than a year of age, and then a year to less than 3 years. And so looking at our primary endpoint, looking at H1N1 and H3N2, you can see the adjusted geometric ratio, which we talked about before, taking the high dose, dividing it by the standard dose, that it was 1.65 for H1N1 and 2.1 for H3N2, so meeting superiority. Here is just looking at the HAI titers for the 4 different antigens, looking at baseline and then looking after 2 doses. And this is looking at the titers, and you can see for the high dose, after 2 doses, it was higher for H1N1 and H3N2. This is just a nice way of visually saying what we talked about in the previous slide. When we looked at safety data, tenderness and pain were the most common in 40 to 50% of the individuals in both groups. And then systemic, you can see that they both reported. We also looked at what were factors associated with the higher adjusted geometric mean ratio. For H1N1 and H3N2, we showed that high dose was associated. Also, if you had a higher baseline titer, and then time post-transplant, and B cell. And then only for H3N2, having a history of graft versus host disease is associated with the lower geometric mean ratio. As you saw, for an efficacy trial, you actually have to have over 30,000, and that's just not going to be possible. So we did try to do some active surveillance. In the high dose group, there was 7 cases of influenza, but I want to point out that 4 of them were due to Yamagata, and that was not included in the vaccine. And then there were 6 cases of the standard dose, and they had one individual that had Yamagata. So we concluded that in the pediatric population, 2 doses of high dose were superior to 2 doses of standard. High dose was well tolerated with pain and tenderness as the most common. Influenza breakthrough was uncommon, and the disease severity was not present. And then we do have some future studies where we gave the same regimen. We call it the repeater. So if they got 2 doses of high dose in the first year, they came back again, and we gave them 2 doses of high dose in the second year. And so stay tuned for that publication to come out. And then we did the adult trial with 4 of the sites listed here, also published in CID, same design, just different age groups, and we went down only to 23 months post-transplant. And the only difference here is we actually collected a nasal swab at each of them, regardless of symptoms. 124 were randomized and vaccinated, 64 were in the standard dose group, 60 in the TIV high dose group, 57.8 was our median age, 38.7 females. This one had predominantly more white compared to our pediatric population, and the median time to transplant was even earlier at 5.6 months. And this is looking at the geometric mean fold rises. And so another way of presenting it is that when you look at baseline, you can see both for the standard dose QIV and the high dose that from baseline, each time it was higher. And then when we looked at the adjusted geometric mean ratio, and that's the third column there, you can see for visit 3, it was 2.03. And then even at visit 4, we showed durability at 1.87. And then B Victoria, both of them, both at visit 3 and at visit 4, had a ratio from baseline of 1.63. So once again, suggesting that the 2 doses of high dose was superior to 2 doses of standard. And this is just so you can see the fold change from baseline graphically. And then when we looked at factors associated with higher adjusted geometric mean ratio at visit 3, once again, the log base titers were significant for A, H3N2, and B Victoria. Also, when you adjust for everything, high dose was associated with higher adjusted geometric mean ratios. You can see here CD4 counts and time post-transplant. Once again, I'm looking at the safety. Around 30 to 40% had reported some kind of solicited adverse event on their memory aid, with tenderness once again and pain being the most common. And then just wanted to show the days here that predominantly the local reactions are really happening in the first couple days. For breakthrough influenza, there was only 4 cases in the high dose group, but once again, you can see 2 of those cases were Yamagata, which was not included in the vaccine, and 2 doses of the standard dose were H3N2. This is one of the last slides looking at the WHO biological standards for influenza vaccines. So every year when they're having new strains, it's sometimes difficult for them to do studies, but they want to make sure that to get a cohort, they want to make sure from baseline that the geometric fold ratio is greater than 2.5, that the seroprotection is greater than 70%, and that the seroconversion is greater than 40%. And so this is busy, but what I'm just wanted to let you know, because if you can go look at the actual numbers, but the high dose met all three criteria. So having 2 doses of high dose in the adult stem cell population, they had a higher geometric mean ratio, seroprotection, and and they met those criteria. So it was just as if someone who is not immune compromised getting 1 dose of standard. And then the same thing for the pediatric. The high dose was the only one that met all three criteria after having 2. So it's pretty awesome. So in summary, immune-compromised hosts are at increased susceptibility to respiratory pathogens and associated higher morbidity and mortality, especially with influenza. Responses to vaccinations are lower to healthy controls. Really important, we didn't touch on this, but to vaccinate your close contacts of these individuals, especially for influenza vaccine. Vaccine trials are essential to determine the optimal strategy and should be able to be prioritized so we can answer really important knowledge gaps, not only in just influenza vaccine, but now we saw with the COVID pandemic. And that 2 doses of the high dose is a practical strategy and could be implemented in our stem cell transplant population. So with that, I will stop. Oh, just so I think the question is just giving IVIG. If kept high enough, is that enough? That is going to be a sub question within ours. We actually didn't restrict if someone ended up getting IVIG as part of their regimen, but one of the things, it's passive, and then protection, and not all of them are going to have the actual antibodies that are specific to the strain that's circulating. So one of the things that we have to be careful about, if we don't know if it's specific to what's the strain that's circulating, just by giving IVIG may not be enough to give protection. Excellent. Thank you all very much for being here, and I hope you have a wonderful day.